Hello, everyone, and welcome back to another episode on health from the Blue Squad. And joining me today is somebody you should actually study because he has run multi-billion-dollar corporations, big entities, and his philosophy is to make technology bend the cost curve. And he's doing Yemen service in that area. I think I'm not fully qualified to, summarize his credentials, but I know that he ran Rice Health before AristaMD. He is the CEO of AristaMD at this point. Correct me if I'm pronouncing it wrong, Keith.
Spy on.
Right. And Rice Health had over 60,000 or 6,000 employees across the country. They did a lot of work with aligning fee-for-service operators to get into the value-based care global risk model. And at AristaMD, what he's doing is he's trying to address the problem of specialty care, the fragmented nature of the specialty care, where he's providing a platform for primary care physicians to get to that specialty care at the right time and at the right cost as well. And in order to do that, what he has done is he has put in a layer of registered nurses who accumulate the patient records and all the information so there is no duplication of care. So the whole idea is avoidance of cost. And according to what I've read from him, he has improved the ROI to 4:1. And I'm sure he's going to explain all that to all of you, doing a lot of service on the value-based care and making it better. I will ask Keith to introduce himself if there is anything left.
I think the appropriate thing would be to step up and drop the mic. Well said. Thank you for the very kind introduction. I think just in short order, I've been in the healthcare space after a successful career in technology and finance for 15 years. I moved into healthcare in 2010 with the intent of bending the cost curve backwards for domestic healthcare, because to have something that consumes 1/5 of the GDP and 2 times the per capita cost of other developed nations, and to have the outcomes in the bottom third of the globe, that is as close to a crisis as I can see. And that's not something I wanted to leave my kids with. So, being a part of a couple of larger Fortune 500 provider organizations, I quickly saw that, big and good are two different things in healthcare. And, when it really comes down to it, there are 9 sicknesses or chronic disease conditions that are over 80% of the $4 trillion spent in healthcare can be attributed directly to. So the old phrase of follow the money. If you want to solve a problem, where's the money going? Get in front of that. So it's really a chronic disease management side of things. Not surprising for anyone that's looked at it. Look, the older we get, the sicker we get, the more costly things get, right? When people get one of those, usually they stop doing all the other healthy activities, including movement, and then they start to pick up the other ones. It's just a negative. It's a really crappy outcome. So I looked at a variety of different service delivery ecosystems and really came to the conclusion that all of the different solutions for chronic disease management that are out there, whether they're a virtual first, whether they're a technology enabled, whether they're traditional brick and mortar, they all have one thing in common that they're lacking: somebody to quarterback the care across all of these things for the patient. This is about the patient. Hello. And most of the patients that are in here are older. They don't know where to go. They're kind of left in the wild. And then there's information that's highly fragmented. If Aunt Judy if Aunt Judy's seeing Dr. Phil, her primary care, and then Aunt Judy gets referred over to Dr. Johnny, the orthopod, that information from Dr. Johnny very rarely makes it back to Dr. Phil. And so the person that in the United States service delivery ecosystem that's responsible and accountable for coordinating care is left in the dark. So no kidding, the care coordination isn't going to happen. The sicknesses are going to progress. The patients are going to be unhappy. The docs are going to get burnt out, and the costs are going to go up, and the outcomes are going to go down. Kind of Captain Obvious. So what I found after building Rise Health to the introduction, which was a risk-bearing primary care aggregator. So we buy primary care groups that were doing well by a medical loss ratio, actuarial assessments. We were actually able to see those people, even though they weren't getting compensated for delivering in a value-based care environment, their practices of proactive patient engagement, of follow-up, of chronic disease management actually would bode well. So those are the people that already, the clinical groups that said, I don't want to practice only in this fee-for-service world where I get paid for sick care, episodic. I actually want to do something different, and I'm doing it even though I'm not being compensated for it. So we created a different ecosystem for them to work in, change the compensation, change the data, change the care teams. And in doing all of that, here's what I found. Access to specialty care. Specialty care, let's call the three biggest one, oncology or cancer treatment, cardiovascular, and in the cardiometabolic ecosystem, and then MSK or orthopedics, right? And especially as we get older. So what I came to the sad conclusion of is, even though oncology, I'd like to do more, I can't be proactive with oncology. I really can't predict at this point in time. Maybe GMs in the future will. But I can't really predict who's going to get it. What I can do when somebody has it, try to give them a better quality of life, but it's really a drug management side of things. Cardiovascular and orthopedics, however, are ones that we could identify Aunt Judy before that knee fully gave out and before she crashed into the emergency room because there's something with her heart. We could identify that. We could get her in. We could do certain basic things for her that would prevent her from, again, having to crash into the emergency room, having to have unnecessary procedures done, spending time in the hospital. And anytime somebody goes to the hospital, the risk of hospital-acquired infections, largely outweighs any gains they have. And so all of these things are bad because they're reactive. The ability to use, modern big analytics to say, based upon all of these other contributing factors, if somebody actually had the data and they compared what's in Aunt Judy's EMR, electronic medical record, compared that against information that lives in health information exchange, compared that against normative population information on a local basis, you could identify things that make Aunt Judy ripe for a problem and address it when it's small, like when the front yard perhaps has a little brush fire instead of the entire house being on fire. So, those two conditions at AristaMD, we work with primary care groups on solving. Because today, Aunt Judy, when she goes to see Dr. Phil at primary care, Dr. Phil says, hey, we should send you to go see a specialist. Well, first of all, it's between 3 weeks and 6 months for her to get into a specialist. The specialist then orders a bunch of tests, even though a bunch of tests were done. Invariably, that specialist, she's not really dealing with the MD. She's dealing with a nurse practitioner or a mid-level or an allied health person. They don't necessarily know all of the right tests. So now we've got more tests and more time passing and more visits. And all this while, Aunt Judy ain't getting any better. So she's unhappy. We're putting that unnecessary cost on the system. And now I come back to Dr. Phil. And Dr. Phil, in a value-based care world or a global risk world, is paid a per member or per patient per year fee to manage all of the care that's there. Not just that episode or her Aunt Judy coming in to the PCP, but it's to manage hospitalization costs. It's to manage all the specialty costs. So now you have Dr. Phil, who's supposed to be quarterbacking care. Dr. Phil doesn't have the data, doesn't know what's happening. The specialist doesn't really, the specialists care about their patient, of course, but they're incented to do procedures. They're not incented to do consults. Completely backwards ecosystem. So what we said at AristaMD is we work with those primary care groups that are taking global risk or full risk on a patient, because we all agree that over a period of time, we should be paid on outcomes. Clinicians should be paid on outcomes, not inputs. And we should be able to pay more for those people that are getting better outcomes. God forbid we actually encourage what we talk about. And we give them different resources. So that's what we do. So instead of Aunt Judy in that situation having months of back and forth and Dr. Phil being frustrated and Aunt Judy being frustrated, we simply take Aunt Judy when she is leaving Dr. Phil's office. We have one of our nurse navigators get in touch with her under Dr. Phil's brand. So it's somebody she's familiar with, right? Because We believe the most important relationships in healthcare are with clinicians and their patients, and everything should be done to reinforce those. Talk about people not complying with care plans. Those care plans come from an insurance company they don't know, that they don't understand why, and the primary care usually isn't involved in the loop. Well, why don't we take the people who are supposed to do the job they have a relationship with, and God forbid, give them the tools and resources to do this. So we're calling Aunt Judy. Our nurse is going through doing all of the onboarding questions, so it's easy for her. Then we are scheduling within 2 days after that a virtual call with a specialist who is an MD, not a nurse practitioner, nothing against, but you kind of want to do it right the first time. If you have an MD who's doing the intake and they can do the assessment, it's just more efficient to do it that way. So we have an MD who does all this, and that MD is not incented to do a procedure, as most of the ones that have physical presences are. They're incented by Arista to do the right care assessment and right care plan. We then manage that entire process. We put all of that data back into the primary care's doctor's electronic medical records, so they have it. So Dr. Phil now has everything about Aunt Judy and what's happening. We coordinate with their care teams. So we've taken waste out of an ecosystem by unnecessary tests and visits. We've taken time out of an ecosystem. We've taken cost because we can identify those things that are critical early before they go. And then Aunt Judy's happier because, a couple of days after seeing Dr. Phil, she's actually figured out what needs to be done and is somebody that's responsive to her. Dr. Phil's happier because he's getting the data back and Aunt Judy isn't pestering him and he doesn't know, he knows what is going on. And then even the proceduralist. So let's say that Aunt Judy was going through an orthodontist. Johnny the cutter, Johnny the orthopedist, Dr. Johnny the orthopedist. Dr. Johnny today would have to do a series of consults before he could schedule a procedure with Aunt Judy. Well, he gets paid 14 pounds more to do a procedure than to do a consult. If you had a full schedule, what would you do more of? Let's just, follow the money, right? So why don't we create, and that's not to say that specialists are economically driven. We all have an opportunity cost that we look to. The specialists simply have been conditioned by an ecosystem to do that. So now, when Arista is there, when Aunt Judy does get referred to the specialist, he doesn't have to do the consult. So we make the time way more efficient. So we're taking waste out, improving net promoter scores of clinicians and of patients, and driving the cost down, beginning with two of the largest cost categories, which again, cardiovascular and orthopedics are, and with primary care groups, because we believe that value-based care is one of the last macro levers, if you will, that we can do to affect healthcare reform on a structural basis, to drive those costs down and to improve the outcomes. So that's how we are working within an ecosystem.
No, so here is what I don't think we should be embarrassed to say that people are driven economically. I think that is a fact. Whether it is doctors, they are human beings. And value-based care in itself is a financial tool. As far as I'm concerned, it's an incentive, financial incentive to deliver better care. So having said that, one of the things that I am hearing that you're saying is you're putting the nurses on. So you are not necessarily running the practice, but you're embedding a nurse practitioner within that practice. So in terms of your payment, who is bearing the cost? Is it
the primary care, because they're the one in that risk agreement, right? What we're doing is we're reducing by all of this work we're doing, whether it's our base e-consult business, which a PCP says, should Aunt Judy even go to a specialist? Behind the scenes, we do a nice peer-to-peer e-consult to tell them whether or not or to affirm a care treatment plan. So that's let's say the 50% that don't need to go to a specialist, we're taking out with our base offering. Then in our nurse navigators live within the primary care practices electronic medical record. We're all HIPAA compliant. We've been doing this for a decade. This is not new stuff, right? So we make it easy for that primary care to say, need an opinion on what to do with Aunt Judy here. Our nurse navigator goes in, grabs all the information from an EMR, other areas, all the things that a specialist would need to know, but you don't want a PCP doing all those clicks because that's just inefficient. So they do that. So there's a rapport and a relationship. And then when we go to that second half, so the half that actually do need to go to see a specialist, right? We already have the information about Aunt Judy. Our nurses are doing that. So when they're calling Aunt Judy, It's an even warmer, well-introduced, not like a cold and, well, tell me your name again and your date of birth. And Judy's like, wait, I thought you were calling on behalf of Dr. Phil. Don't you have all this? Right. Like,
Right.
it's just some basic human sides of things. It comes down to a connection with people. Our business is change management with clinicians, change management with patients.
So here is what I'm trying to understand. And going back to, I think I'll focus a little more on the financial incentives and those kind of things, right? So I have held a lot of discussions in Switzerland. I mean, in America, we know, right? There is more popularity, but it's not become mainstream value-based care. In fact, I was a little bit surprised when I talked to Dr. Shulkin in one of our previous podcasts, right? When he said, is it going there? He did not, I don't want to put words in his mouth, but my interpretation was that it is not becoming mainstream in that way itself. And then when I was talking to the Swiss people and the other people, the general impression I'm getting is nobody is, unless the government moves to introduce this VBC, nobody is really incentivized to make any changes because the doctors or the providers are happy with the fee for service. They know this, they get this thing, right? And the insurance providers are also like, okay, I don't want to mess up anything. This is a system that works, so we don't want to change it. And the whole world, I mean, in India, right, I keep telling people there are 10 super specialty hospitals within 15 kilometers of where I'm sitting right now. Super specialty hospital. And in India, the hospitals are minimum 1,000-bed hospitals, right? Big, large hospitals. And everybody is following the American model, which is the fee-for-service model kind of thing. And none of them are going to be changing their way they are doing things because the other one is uncertain.
Yes.
That's what I was going back to. This whole thing is, I think viewers need to know, what is all this global risk and is it really going to make money? There are stories.
Yeah. Can I share with you a government program perspective?
Right.
So let's talk about patient populations first. So I'm specifically focusing on the highest cost population, which is seniors.
Yes.
So
you'll get more of them pretty soon.
Right. So there are Medicare is the primary government payer for that, right? And then you have a private pay carve out called Medicare Advantage, which is Medicare with some other ancillary benefits, dental, vision. But the quid pro quo or the trade-off is patients have to go into a payer's narrow network, meaning the people that the payer has contracted with to deliver. So in a Medicare Advantage, the primary care docs, a majority of those are taking risk. So it is happening there. So when I take MA, so that's happening and that's in play. And that's where some of the larger, more successful groups, whether you look at an Optum in what they've done post DeVito, right, and flipping the script and really being able to deliver upon this model, the Optum clinical side of things, in Oak Street Health or the CenterWell or Conviva, to an Archwell or ChenMed, like all of those people are doing this and they're delivering effectively on this model. Now we look at, but what about the other people that are in Medicare? So the regular Medicare population, if you will, today that's about 48% of the total senior population is regular Medicare. 52% is in Medicare Advantage. So now we go to the 48. Of that 48, the government specifically has put together accountable care organization programs to take those, the patient population, if you've heard the CMS objectives, if you've listened to any of the prognosticators and you've listened to everyone from Dr. Oz down to Chris Klum at CMMI, the objective is to get all 48% of those patients into an ACO program by 2030. So we actually are seeing fundamental changes happening. And by the way, those programs today kind of look like an MSSP or a shared savings program, or REACH, which was the predecessor for direct contracting. CMS and CMMI have just announced Access, which is an extension of, and it's really about technology-enabled care and having better reimbursements associated with technology-enabled, and then the outcomes with it. ASM, which is the ambulatory surgical model, which actually forces specialists in certain categories into mandatory enrollment in this type of work. And it's in cardio. There's the cardiometabolic ecosystem as well as lower back pain. And then, I'd look at LEAD, which is out there, and it's again focused on cardiovascular and MSK. So we've got in LEAD, by the way, is a 10-year program. That's not a changing of the guard administration. These will change. So I would say that there's been a seismic shift, the same negative approach to tariffs that we're all like, this administration at least does appear to hold accountable. And we're seeing thoughtful programs being rolled out in the ACO space that will mandate that fee-for-service is largely gone by 2030 in the senior population. It's the only population I can speak to at this point in time. And it's the costly. So, my dad, a great fisherman on small lakes, used to say, why don't you fish where the fish are? Right. So, that's my simple take. So these programs are happening. The economics are changing, and kind of hey, this too shall pass, which hospital systems are infamous for doing, right? Hey, well, these programs will pass capitation, but no. This is not one of those that will happen. You can't continue to run a business based upon a 40-year-old facility that you got to keep heads in beds. That is so far gone, right? So,
it's a good thing. It's a good thing. Use.
Hell yeah. Yeah, hell yeah. I mean, why would you send somebody to this 40-year-old facility that you were charging $10,000 to the insurance company? Patient very rarely sees this, to the insurance company, when the patient could have the same surgery done in ambulatory surgical center, same procedure, get discharged the same day for a third of the cost, and outcomes are better, right? You're like, you got to change and pivot. So at a macro level, policy-wise, things are changing. At the MA plan, things are continuing to change, where there's a certain level of stars, which is how programs got certain dollars and reimbursed for those. Even stars programs in HEDIS and the like are changing to be more of an outcome-based, not an administrative-based, and to have it based upon patient satisfaction. So we are seeing a macro shift happen. The PCPs largely are not happy with this ecosystem because, what a PCP made 15 years ago, today, they make maybe 35% of it. So if they wanted to keep their earnings whole, they'd have to see 4 times the number of patients. The most recent studies say it takes 27 hours in a day for a PCP to do everything they need to do. So in other words, it's not sustainable. The specialists have had, in a fee-for-service world, they're just incented to do procedures. Those are the ones that we need to figure out what to do with. And those are the ones like the ambulatory surgical model that the government's put out is beginning to address that. And those things take effect in 2027. Does that kind of give a different color?
No, what I was going to say is a good thing you reiterate that, because I bet my company on that value-based care is going to be the mainstream. But again, going back to what I think the point I was trying to make is, it is because the Medicare is the largest payer and they are pushing for this. That is why this change is happening here. But I don't know in the other countries if there is such an organization that can push for these things. So especially in India, the insurance industry is not as strong, because here they still pay out of pocket, most of the people. I think only in the last 15 years, the insurance have caught up. Even then you pay. And so it's not like our place in the US where, you had to get the insurance approval and go and get all these things. And it is completely disconnected from the customer and the payer, the whole setting, right? And so that's what I was trying to say. But I think the risk models, and I think that's what most people have to gain a little bit more understanding, right? And I'll ask you to explain some of the risk models just in a simplified fashion. And the other point that I wanted to discuss with you is not a statement or anything. It's just that when I see the value-based care model coming in, I think it is also a shift from pure technical expertise in delivering care to managing an institution and the patients. The emphasis is shifting from, okay, you know how to build houses. Now let us see if we can build an organization that can deliver. So it's all about how can you plan a good delivery model, a care delivery model that is, there is no deviation of care, there is standardization, all these kind of things. And like I said earlier, I bet my company on the philosophy that managerial tool has to be a better system, that can deliver on all the 4 components, which is patient engagement, care coordination, reporting. And so going back to what I was saying is, it is at least when I started this, I've been doing this 33 years, right? When I started, thought every doctor thought that he was a great business, but a provider, and they aren't. Some of them are, but this is making them focus more on that management side of things. So on these 2 points, if you can share your thoughts.
Well, so first, I think the whole ecosystem dialogue, right? We can't, to your analog, right? A home builder may not be the best suited to architect the blueprints for entire community that has businesses, that has everything that has the green spaces, everything that's required, because they build houses, right? That doesn't mean they have that competency. So I do believe that in value-based care, a different ecosystem is required. So first, it's the data. How are we giving the primary cares data that they need and not making them read an EMR before they see the patient? But there's so many summary tools that are out there. It's one of the beauties of AI, right? Is you can really have this stuff scanned. You can have summaries done the night before. You can have things even presented at point of care that said, hey, for Aunt Judy, ask these 5 questions, fill in this information, right? Like all of that. So data is there. And it's not just the EMR. It's what's in a health information exchange. It's what's in other areas that you can be more robust. You combine that with what the doc knows, and every doc, there isn't a clinician out there, a majority of clinicians out there will agree that for every disease state, there's an established care protocol and pathway. Nobody argues with them. Why don't we follow them then? Well, I diagnosed this illegal. You're like, no. Hold on. Let's do this right? So how do we give them the data, right? Then how do we make it easy for them, because they're not necessarily used to doing the care management. They're not necessarily used to doing the analysis. They're not used to looking at all the data, having it, and God, they're not used to having the time to freaking do that because they've got to see 3 patients an hour. Well, if you don't change that and figure out a way to give the PCPs time to spend with the people that need all of this complex care management, you're just setting everyone up to fail. So you got to change time and then how we compensate those primary care docs. So now we're doing that. And then we say, well, wait, now at that primary care office, they're really a community connector. So they got to have care management and care coordination in there, because there are all these great social determinants of health programs, social welfare programs that are in a community, but the patient doesn't know what they are. Well, that's where you'd have a licensed social worker connecting those pieces and doing the care coordination. So all of a sudden, you've got a different service delivery ecosystem that you have to do to make value-based care work. You can't just plug docs in who are used to seeing 3 to 4 patients an hour, doing all the documentation for billing and collections. Because by the way, that EMR documentation they're doing has very little to do with patient care. It has everything to do with how you bill and collect for this crazy stuff. We'll talk about a perverted system. Oh my gosh. Highest value of a clinician, of a doc, is spending time with their patients, assessing and caring for them. It's what they can spend the least amount of time to, because they've got to spend all this time in billing and collection stuff that doesn't really matter. I mean, let's throw that thing out. That's where value-based care. And I think that's why docs embrace that when they can get a different type of compensation for it, right? Which is huge. Again, specialists, they still get paid in procedures. Over time, some of the government programs, it'll work and we'll figure that out. But from the primary care side, when I think about the reimbursement, so today, an average senior in the primary care side of things with average acuity or sickness or RAF score, depending on how technical we want to get, of like a 1.1, 1.2, is probably going to see their primary care 3 times a year. And the primary care from that is probably going to get paid $900 to $1,000 in aggregate. There'll be some tests, they'll do some other things. In a value-based care or a global capitation, under an ACO REACH or evolving into the access or the lead side of things, or the AHEAD program if you're in the East Coast of the U.S., that flips completely to they now get paid roughly, again, same patient classification, roughly $1,000 per patient per month. So, or $12,000 a year But for that, every time Aunt Judy has to go to the specialist, that comes out of that $12,000. Every time Aunt Judy goes in for a procedure, that comes out of that $12,000. Every time she goes in the hospital, that comes out of that $12,000. Every time she goes into the ER or as an ambulance service, that comes out, right? So if you look at the average cost of an ER visit, it costs what comes out of a PCP's segment, what they actually have to fund out of that is between $35,000 and $5,000. Well, if you're getting paid $12,000, half of that's gone. One unnecessary ED visit. So you want to make sure that you're doing the proactive things with data to take care of that. Then you don't want Aunt Judy getting sicker because the more sick she becomes, the higher your costs are. So, becoming proactive, managing a patient population as opposed to reacting to when patients come in, right? So having the data to say, hey, Aunt Judy's sister, Thelma, in her other sister, Louise, we've identified that they are likely to have some issues in the cardiometabolic space because we've bounced their data against other data sorts or an actuarial set. Well, they're not appearing on anyone's radar right now. Well, we need to get them in, proactively get them in, see them, care for them, begin on these treatment protocols, right? So it's those types of things. It's the proactive. And it's not calling every patient. It's calling the ones that have the greatest likelihood of creating downstream additional costs and getting them before they get there. So, it's a proactive side of things. So I think the shift goes to a global capitation where you can make meaningfully more money if you do fundamentally different activities. You can't just sit back in the pocket and hand the ball to the running back, to use the football analogy, right? Fee for service. Actually have to think about where you want to run the ball, where you want to pass the ball. Who else should be dealing with this? Where's your offensive line? It's an entirely different playbook. So you've got to give them a different set of tools and compensation and a supporting cast to allow them to do it. And then these payment programs over a period of time really start to make a difference for patients and clinicians alike. So I think I kind of answered both questions together, but tell me what you'd like me to expound upon.
So one of the global risk program is that when I was talking earlier, the Medicare is spending average of $18,000 to $20,000 per patient per year. That is kind of what they were talking about. And so what you said is them paying $12,000, it significantly reduces that. It's not connection, but I'm just thinking aloud on this thing. There's a difference between global risk and then there is another program where there is a limited amount of risk, and then if it exceeds a certain condition, you get additional payment for that. And I think that is one of the areas where one large health system got into trouble recently about unnecessary. So can you just explain those various, because you're
risk? Yeah, the global risk is take it all in. And to me, that's the best system to have because it forces people to be all in. And if you're going to do this, be all in and do this all in. Then there's a partial risk or an upside only risk that it's kind of like being able to cherry pick a little bit. You don't make as much, but you don't have as much at risk. Why would you do that if you need to have a whole new ecosystem to do this. If you're only getting half of what you would potentially get by managing risk well and managing a population well, you're like, well, I don't want to take that on risk, that additional risk on. Well, then you're going to not build the right ecosystem to begin with, and you're going to get half-assed results. You can't cut your way to profitability on a sustained basis, right? You have to grow and you have to do things differently. So there's this partial or upside only. And then there is the full risk is upside and downside, which is the professional fees and the institutional, e.g. the hospital fees and everything else. Then there's a fee element that is only the professional spend side of things, only like the specialty doc visits and PCP. When I look at the total cost of care, PCP and specialty are about 35% of the total bucket, which means 65% is spent in institutions, whether it's inpatient, outpatient, or ED. So to focus on something that's only a third doesn't seem to make sense on things. Nonetheless, there are those programs. And again, to me, discourages. And after doing this for a number of years and seeing things that worked and didn't work, going all in seems to be the most efficient way because then you make the investments to do it right.
Then there is also this model where for pregnancy alone, there is a capitated model. So whatever happens, that is covered, right? So that is
Yeah,
also part of.
actually, so that pregnancy, there's one. Medicaid has some interesting things that they're doing, on the pediatrics. Again, I'm focused on the senior side stuff. We really don't see too many pregnancies with people over, but there are some special programs for dual needs or special needs programs that are out there called PACE, which are they're all extensions of kind of the same thing. There's also one for kidney care. There's a couple of other ones that take
Diabetes.
right? Yeah, diabetes, the cardiometabolic ecosystem. And then there's a behavioral health one that's out there for dementia and Alzheimer's. That's a new program. I think when I look at it, the whole idea of the HCO program is the holistic. When we start to carve out certain specialty, we've now created more silos. Healthcare does not need more silos.
Exactly, yes.
So that's my simple practitioner view of doing.
No, integrated care is what must be done, and that is one of the things that we have focused on when we started our business as an EHR system. So integrated care, there cannot be, including dental and behavioral health, it should all come together, without which there is no way. No, but let me try to shift to the two other areas which I just want to discuss, because this is an interesting conversation and I just don't know how the time is flying. But the thing about what you are doing is that entire patient navigation and care coordination is taken over by you, or it can be you, it can be done the primary care.
The primary care, depending upon their capacity. If they have a full team, we do a light version of it. If they don't, we can do the full version. It's always in partnership with them because it's empowering them.
No, understood. So that function, which I am going back to that managerial function, becomes critical, and it means that you can take the pressure off the provider and help him focus on the more important parts while this part is being done. So care coordination, care navigation, and preventative care becomes really, really critical. And I think, I don't know if I'm pronouncing this right, Munawar Greshammer Health, that case study that we read about, that they saved $100 million just by following these three things. So they took a population, the same amount in Medicare Advantage and the regular one, and the same kind of patients. And when they did at the end of the year, they saved about $100 million just by doing the preventive care, which is basically following up and calling up and doing the care navigation, care coordination, tracking care deviations, and all these kind of things. And they did that. So that becomes really, really important. The second area that I wanted to talk about is patient engagement. And this is very close to my heart, because the first product I launched, this was way before its time, was a patient portal. So we were part of this open source community, Open EMR, and we were one of the biggest contributors, and it's one of the largest open source EMR systems out there. And because everybody was downloading the code, I thought there should be one central portal that can connect all these things, right? And
wait, do you want to make it easy for the patient? Come on.
Yeah, but the thing is, none of the patient portals had success. Nobody was using it. Even MyChart from Epic or everybody else, the patient portals have not been using it. And the thinking at the time was, patients don't really have the need or the care, or they don't really appreciate it, or something like that. But now, during the last 3 months, what has happened is, with AI, it seems patients are using it the most to find out about their conditions and the follow-up. So what I'm thinking is, all these regulations regarding I cannot answer your question like that and all these kind of things. So the patients were not getting the real answer. It's kind of going to a lawyer and saying, I have this case, can you help me? And it's all very controlled answers, like I cannot say whether I'll win or I will lose, or those kind of things. That's the same kind of reaction. But AI is telling them, okay, this is what it is. And I think they're deregulating a little bit more. I think the latest one that I saw is they're going to allow AI to recommend a single solution rather than provide an array of one, as long as it shows you how it arrived at that conclusion so the doctor can or the provider can validate it, which is kind of like the math test we took at school, right? You cannot just say this is the answer, you have to show the steps.
Your homework. Yes.
So all those sort of things. And so I'm saying when you apply the right technology and give power to the patients, the engagement, I think they talked something about a substantial percentage of use for Claude and Gemini and ChatGPT is health related question. And that's why they're rolling out these things. So comments on both these things, like on the patient engagement piece.
Yeah, it is. So let's take AI in the context of patient engagement, right? Because, WebMD, right, at 15 years old, was the beginning of this, right? And there was all the talk of consumerization, right? Well, consumers are going to go through this and they're going to make their choices. Well, that was largely propagated by consumer product goods companies. They've proven that they have massively failed in healthcare. Healthcare is not a consumer product good. It is a service that's been delivered by highly trained, highly trusted, and respected specialists. You can't replace that with an online source of information. And the amount of training. So I was involved with Watson Health way back when, back in 2012. I was on the Watson Health Advisory Board. And man, I'll simply say this. When you buy the wrong IP or your research and development that's used to train your algo and you don't do the expert opinions and make the investments and all that, you're just going to not get the outcomes, right? So the ball is advanced a lot further forward from that. The fact that, about a month ago, ChatGPT said, hold on, you can't take this, what we've said. You can just take this as information and a recommendation. We are not qualified to do this. That should have been the big warning shot across the bow for everyone who thinks that AI is the answer. There is no silver bullet. There's a bunch of copper bullets that we have to figure out the right sequence in firing them that creates the change that's sustainable. So I think the patient engagement, again, I'm going to the senior side of things. The fact that during the pandemic, more of the seniors got used to just doing FaceTime with the kids and the grandkiddos, right? All of a sudden, we had a positive shift, which enabled telehealth or virtual first to make sense, right? And then people getting more comfortable with making queries about their health data. My mom's 84 years old. She's she just retired from practicing psychiatry. So she's just starting to use some of the AI tools available. So we start to see that. I think that's helpful because when a patient comes into the clinician or they send them maybe a message inside the EMR, inside the portal, and they're like, hey, I read this and I was thinking this with my lab results. What do you think? Man, the docs appreciate that. It's not about being questioned. They're like, oh my gosh, you're taking this seriously. I want to help you more. So I think that's the positive side. And I think that with more information available to patients and easier to get in and easier to navigate inside of like the user views, the portals, it's getting better and the information's getting more robust. If we couple that from a change management of patient engagement with a clinician that spends more time with the patient and actually documents and interacts with them in that type of environment, everyone gets comfortable in an asynchronous environment, as opposed to having to do it in person or having to do it, on a live, like a synchronous environment. So now we can get more efficient with our time, right? We can get better follow-up. So I think that's absolutely starting to happen when we look at patient engagement and where I see AI, really being an accelerator. And look, we now start to see ChatGPT for health, right? It's only a matter of time before these engines, before these large language models start to gain adoption. And where is it more efficient? I don't know. Where is it more efficient in helping a doc deliver better opinions? Is it more efficient?
Radiology?
What's that? Yeah. And look, I happen to love incidental findings. And for those that aren't familiar, Uncle John goes in for, something in the ER in his shoulder. He's got some pain. Well, the radiologist, obviously, the rad tech takes a picture of that, and they're going to give back to the ER doc the direct findings and final read for the shoulder. But what AI also is doing is looking for incidental things in that picture that a human's eyes don't do. right? And I think the incidental findings are the single greatest benefit that we see from radiology or any of, I mean, you can also say ophthalmology benefits from that, dermatology benefits from that, podiatry benefits, anything that you can take a picture and you can find out more stuff and query and train. So I'm very excited about that use case and continued use case, because AI doc is kind of proven that in radiology, but I think we're on the tip of that within other ologies, if you will, if that makes sense.
All right.
Keith,
Educate us. So go ahead. Sorry.
yeah, and I just want to add on to the patient engagement side, right? So let's say, Keith, how do you see the business model of AristaMD changing? Like, let's say that the companies like Hippocratic AI, they have this, virtual calling nurses. So if they take care of the triaging the patients for the specialty, right? So in those scenarios, and let's say that patient adopts those behavioral aspects, how do you see the business model of AristaMD changing in those macroeconomics shifting scenarios?
It's a really good question, right? So if we say that the payment paradigm is changing with the stuff happening in the accountable care organizations, right? So we've got macro payment levers that are happening, but in order to get the real benefit, we've got to get the patients, we've got to engage the patients differently than historically a primary care has, right? Because historically a primary care maybe reaches out one time a year for an annual wellness visit, which they have to do to make sure that the acuity scores are done properly in the RAF and all that other stuff. Now you're actually talking about a primary care having to look at the patient segmentation and reach out to that patient and say, hey, look, I was looking at some things I'd really like to get you in. There are some observations we have that I think is going to make a big impact. Let me schedule you for this, and this date. Then having that holistic view, well, that patient is probably going to be like, I'm sorry, what? Well, how much does this cost? Well, fortunately, in the Medicare world, there aren't these inhibitors, right, for that. So there isn't that cost. Well, I don't want to pay for that. I don't need that. To the wait, okay. By the time that doc is done with that visit, that patient is going to have a different level of engagement and appreciation because, oh my gosh, think about a doctor actually, a primary care actually saying, we've looked at this in your blood test, we've looked at this in your urine, we've looked at these things, we've looked at these other factors. Here's some pieces that we believe you could be at risk for, and here's 4 activities we'd like you to do to prevent that. Here's a couple other things, and here's some literature and some other things to read. I got to tell you, that patient is going to walk out of there and tell their immediate care team, their family, about that doctor. Well, their family is going to get a little bit more involved. Now we've got a healthy ecosystem that's happening. So I think the patient engagement, and look, I'm biased because I've seen this work and not work in different environments. I think the seniors of the PCP, it has to be where it is. I think that AI and just having those consumers that want to know more, be able to ask more, and not come to their own conclusions. Like, don't take what you read, like this whole hallucinations that happen with AI. Good Lord, don't do that. Run it by your doc. Wait, hello, that's a more efficient way, and it's a healthier relationship. So I think the way I would frame it is value-based care really is continuing to encourage that patient-physician-clinician relationship, not an episodic thing. And then as a result of that, the doc becomes more trusted in there, and the doc becomes more proactive. Now we've got better compliance and adherence. And by the way, most older patients are lonely. Having a simple call from a care coordinator or care navigator once a week does dramatically increase their compliance, simply because they're having conversation with somebody they like. In the day of AI, sometimes people forget this is still a human relationship business. Relationships matter. So that would be, does that give you a perspective?
Yeah.
That's what I was checking. But one final question, and we'll go from there. You have improved the ROI by 4:1. So if there are viewers out there, I just, and potential customers for you, I just want you to drive home how you do that so that they can get an understanding
cool,
of
and I know we're at time. Okay.
How they will benefit from it.
Yeah, thank you. It's a great point. So at the end of the day, there's 3 key performance indicators that our customers use and that we use with our customers to measure the efficacy, the impact of the programs. One is an actual cash-on-cash return on investment. We're between a 3 and a 4 to 1 return on investment within a 12-month period. So within that same calendar year of reimbursement, that same calendar year of cost, there's reimbursement. They're not having to wait 2 to 3 years, which is part of the problems that exist. 2, net promoter score of patients. Hey, I can show you how we've reduced costs, but if your patients aren't happy, that's a real problem, because now you're going to get compliance right. And then all this whole games of people who play denial of care, all that whole stuff. Net promoter score is the guardrail against it. And then the third is net promoter scores of the MDs and the mid-levels, the nurse practitioners. We need to see a 20%, at least in the first 2 years, a 20% improvement in net promoter scores of patients and providers. Pretty simple. Happy docs equal happy patients equal healthy patients, happy and healthy patients also equal healthy docs, happy docs. Now we're starting to short circuit the burnout, especially looming in PCP. So we use those measurements, and that's why after a decade, we're the largest at doing this. We have virtually nobody that leaves us after doing this, because it's just a different way of doing what they all signed up for, which is delivering great patient care. And now we're able to help them do it in a more economically sustainable
And
way.
who are your customers? I mean, just
So our customers are the larger risk-bearing primary care organizations that would range from like a CenterWell and Conviva to a ChenMed to the Optums of the world to the Archwells, folks like that. Primary care groups, generally with greater than 75 docs, who are in one of those value-based payment programs, whether it's an MA or an accountable care organization.
you're a value-based care enabler.
We are.
And with that, I'm concluding my questions. And do you have any other comments or anything you want to ask?
I love the fact that you talk about the patron portal in the beginning. Sometimes people forget about the patient and all this change, right? All this stuff we talk about. Look, if we make it easy for the patients to do what we want them to do, likelihood is they're probably going to do it because it is in their best interest. People forget about the patient and making it easy for the patient and all of this and understanding the patient side. I love the fact that you began with it. I love the fact that we're talking about an EMR that maybe isn't something that was designed in 2010 for billing and collections, maybe is designed to actually deliver clinical to facilitate clinical documentation that actually enables better patient care and better outcomes. That's what EMRs should and could do. So I love the fact that that's what you all are doing.
Yeah.
So
The philosophy of just holding medical records has shifted, and it is about enabling operations efficiently in terms of all the 4 areas you talked about: revenue cycle or patient engagement or care coordination. That's what we do. But thank you very much for giving us your time, and I enjoyed the conversation, and hopefully I'll meet you in person when I'm there.
wonderful. I look forward to it. Thank you very much. Really appreciate the time and the dialogue. Have a great rest of your week.